Welcome to ABC tutorial. Today we are going to talk about hypertensive disorders in pregnancy. Hypertension is generally defined as blood pressure greater than 140/90 mm mercury. Hypertension in pregnancy is defined as blood pressure greater than 140/90 mm mercury, measured on two different occasions at least 4 hours apart in a pregnant woman. Hypertensive disorders in pregnancy can be broadly divided into 4: pregnancy-induced hypertension, preeclampsia, eclampsia, and chronic hypertension. Pregnancy-induced hypertension occurs when the blood pressure is greater than 140/90 mm mercury on two different occasions, measured at least 4 hours apart after the 20th week of gestational age. While preeclampsia occurs when the blood pressure is greater than 140/90 mm mercury, measured on two different occasions, at least 4 hours apart after the 20th week of gestational age in the presence of proteinuria. That is, preeclampsia is pregnancy-induced hypertension plus proteinuria. If a woman with preeclampsia develops seizures, she is said to have developed eclampsia, which means eclampsia occurs when a woman with preeclampsia develops seizures, most often generalized tonic-clonic convulsions. Chronic hypertension is defined when the hypertension develops before pregnancy or before the 20th week of gestational age, or if the hypertension persists beyond 12 weeks after delivery. Preeclampsia can be defined as an idiopathic progressive multisystemic disorder that is characterized by blood pressure greater than 140/90 mm of mercury on at least two different occasions, measured at least 4 hours apart in the presence of significant proteinuria, and it is usually diagnosed after the 20th week of gestational age in a previously normotensive non-proteinuric woman, and it usually resolves within 6 weeks after delivery. In summary, preeclampsia is hypertension in a non-hypertensive woman with proteinuria diagnosed after the 20th week of gestational age. Significant proteinuria can be defined as a 24-hour urine protein greater than or equal to 300 mg or urinary dipstick of 2+ or more. Significant proteinuria is also urinary protein to creatinine ratio greater than 0.3. Preeclampsia can be mild or severe. In mild preeclampsia, the blood pressure is greater than 140/90 mm mercury, but it is less than 160/110 mm mercury. While in severe preeclampsia, the blood pressure is greater than 160/110 mm mercury. The etiology of preeclampsia is generally unknown, that is, it is said to be idiopathic. However, abnormal invasion of the spiral arteries of the uterus by trophoblastic tissues have been postulated to be the cause of preeclampsia. Also, genetic predisposition and abnormal immunological response of the mother may be the cause of preeclampsia. Abnormal lipid metabolism have also been postulated to be the cause of preeclampsia. Preeclampsia generally affects multiple systems in the body. In the cardiovascular system, there is hypertension and generalized edema. In the renal system, there is glomeruloendotheliosis, which is deposition of fibrous materials beneath the cells of the glomerular capillary endothelium, leading to occlusion of the capillaries. There is also proteinuria. In the hematological system, there may be thrombocytopenia or reduced platelet counts. In the liver, there may be elevation of liver enzymes. Sometimes, this elevation of liver enzymes may occur in conjunction with hemolysis and low platelet count, in which case it is known as L syndrome. In the central nervous system, there may be seizures, in which case the preeclampsia is said to have developed into eclampsia. The risk factors for preeclampsia development in a pregnant woman include the age of the pregnant woman, that is less than or equal to 18 years of age, and also greater than or equal to 40 years of age. The risk of preeclampsia is also higher in women with previous history of preeclampsia and in women with family history of preeclampsia. Preeclampsia is also more common in women who are pregnant for the first time, also known as primogravidity, and when the pregnancy interval is greater than or equal to 10 years. The risk factor is also increased in people with obesity, people with multiple gestation, and also in women who have had children but are now pregnant for a new partner, that is, new paternity factor. It is also more common among blacks and also in women who have SLE, systemic lupus erythematosus, and also in women with underlying medical conditions such as women with pre-existing hypertension, pre-existing renal disease, pre-existing diabetes, and the women with antiphospholipid syndrome. Preeclampsia is mostly asymptomatic, but in addition to the elevated blood pressure and proteinuria, they may present with flu-like symptoms, counter headache, visual disturbance, epigastric pain, and edema. In women suspected to have preeclampsia, the following investigations are done to confirm the diagnosis and to rule out complications. The investigations include complete blood count, urinalysis, platelet count, clotting profile, liver function test, serum renal profile, ultrasound scan in order to determine the size of the fetus and the amniotic fluid volume, and also fetal cardiotocograph should be done. Treatment of preeclampsia depends on the severity and the gestational age of the fetus. Women with mild hypertension without proteinuria, that is, women with pregnancy-induced hypertension, are generally managed as outpatients, while preeclamptic patients are managed as inpatients. If the fetus is immature, the patient will be placed on bed rest and nursed in left lateral position. Their vital signs are monitored regularly. They are given antihypertensive medications to lower their blood pressure. Magnesium sulfate is also given in order to prevent development of seizures. Also, the fetal biophysical profile should be measured in order to know the well-being of the fetus. However, the fetus should be quickly delivered if the blood pressure is uncontrolled, or if the fetal cardiotocography is non-reassuring, or if there is development of seizures, that is, if the preeclampsia evolved into eclampsia. In a woman with preeclampsia in which the pregnancy stem, the management involves three phases: administration of antihypertensive medications, magnesium sulfate administration, and delivery of the fetus. Antihypertensive medications usually given in pregnancy include labetalol, hydralazine, nifedipine, and alpha-methyldopa. The magnesium sulfate is usually given as 14 gram start, which involves 4 grams given slowly intravenously and 5 grams into each buttock. They are then maintained on 5 gram magnesium sulfate given every 4 hours. This is continued until 24 hours after delivery or the last convulsion. This is known as the Bishop regimen. Other regimens such as the Zuspan regimen are also available for the administration of magnesium sulfate in preeclampsia. Fetus can be delivered via vaginal delivery or via cesarean section, depending on whichever route is faster and safer. Complications of preeclampsia include abruptio placentae, in which the placenta separates from the uterus before the onset of labor, cerebral hemorrhage, renal failure, heart failure, preterm labor, liver failure, HELP syndrome, which occurs when there is hemolysis, elevated liver enzymes, and low platelet count, intrauterine growth restriction, and intrauterine fetal death. Also, the preeclampsia may develop into eclampsia. Eclampsia occurs when there is convulsion in a pregnant woman during pregnancy or during labor or within 10 days post-delivery, and there is no other medical, organic, or biological etiology for the convulsion. That is, if a woman with preeclampsia develops seizures, she is said to have developed eclampsia. In the treatment of eclampsia, the pregnant woman is resuscitated and stabilized, and the fetus is delivered as quickly as possible. In resuscitation and stabilization of the mother, the airway patency is maintained, adequate breathing and ventilation is ensured, adequate blood circulation is ensured, magnesium sulfate will be given to terminate and prevent any convulsion. Antihypertensives are also given to lower the blood pressure, while the fetus is delivered via vaginal delivery or cesarean section, depending on which route is faster and safer. In administration of magnesium sulfate, there is possibility of magnesium sulfate toxicity. Signs of magnesium sulfate toxicity include loss of knee-jerk reflex, bradypnea or respiratory rate less than 12 cycles per minute, oliguria or urinary output less than 25 minutes per hour, slow speech, somnolence, and cardiac arrest. The antidote of magnesium sulfate toxicity is calcium gluconate.